Thank you for the organizers for such an innovative initiative. And good evening, students and colleagues. And very much thanks to Dr. Amrit, who has really worked very hard in, developing these OSCEs. So what we have decided is we have total of 20 OSCEs, which would be spanning over around 2 hours. And the first 10 OSCEs I'll go through, and then later on, Dr. Amrit can take over. Is that okay?
Yes, sir.
Okay.
Thanks.
So without wasting time, let us start with the first part of our OSCE session. So you have a 29-year-old G2 P1 mother who is around 30 plus 4 weeks, and she presents in a labor room with preterm labor. Her cervix is 3 centimeter dilated, and the membranes are, yet intact. So in this scenario, what would be the two pharmacological interventions that may be recommended antenatally to improve outcomes in this fetus? And Swati, how exactly are we looking at the answers?
Sir, the participants will, once you have said, asked the question,
Yeah.
you need to give around 30 to 60 seconds for them to write down the answer in the chat box. And then simultaneously, you can go through the answers, sir. And then after a minute or so, the answers can be discussed.
Many have started answering that.
Okay.
Yeah, so many of them have started answering in the chat box. We can have a look at the
So I
chat box.
think better is we go through all the questions because every bit has 5 questions in that.
Yes, yes, sir, yes.
So
Okay, sir.
the second one is that what's the gestational age that these antenatal interventions generally are recommended currently? And mention one important neonatal benefit associated with each of the medications. Mention one important adversities, with these medications. And is this situation an indication for antibiotic? So I need to look at the chat box, right?
Right, sir, right, sir. Few questions, a few answers here.
Yeah. Anyway, this way, I think it's a bit difficult to go through all the answers, but definitely they can retrospectively see what they've answered and we can display the answer slide. Is that what you're doing in the past?
We are discussing it simultaneously, sir. As per your wish, if you want to right away go to the answers, that is
Yeah.
okay.
So there are most, answers are, answers for the bits, not the complete answer. So what I would suggest is that you wait for a minute till you read all the questions and try to answer all the questions in one message. So that will be more relevant from the next question onwards. So a lot of answers which are, correct, and we'll go through the answers. So obviously the two important antenatal interventions would be the antenatal corticosteroids and magnesium sulfate. I think most of them have answered that correct. As far as the antenatal steroid, the indications would be that if a mother is there with impedant preterm labor and she has a gestation of 24 to 34 weeks, so that would be the indication for antenatal steroid. And these are standard operative guidelines as far as the Ministry of Health and Family Welfare 2014 is concerned, and that is what we follow in India. And the antenatal steroid we give is the dexamethasone. The second important antenatal intervention is the magnesium sulfate, and this we give when the gestation is less than 32 weeks. So the main advantages of antenatal steroid, most of us know, it's a reduction of RDS, intraventricular hemorrhage, necrotizing enterocolitis, and mortality. And magnesium sulfate reduces the risk of CP, moderate to severe CP. The antenatal steroids may cause hypoglycemia, even though they cause hypoglycemia, but that's quite manageable. And it doesn't need any correction as such. And the magnesium sulfate may cause respiratory depression and low calcium levels. So you have recent articles which tell to screen all babies who receive magnesium sulfate antenatally for impotent early onset hypocalcemia. So that's one important adversity one need to look at. And obviously, as the membranes are intact in this case, the antibiotic is not indicated. So as I was telling that in India, we follow the antenatal corticosteroid Government of India operational guidelines. which came in 2014, and they still, stand valid and they've not changed yet. So whenever you get a mother who's between 24 to 34 weeks of gestational age reporting with complaints of labor pain in between 24 to 34 weeks, then you check whether the pregnant woman is in true preterm labor using the table given below. So there's at the bottom, you can see a table which clearly mentions that how to differentiate between a true labor pain and a false labor pain. So the flow chart thereafter only holds good if the mother is in a true labor pain. So that is if the contractions begin irregularly but become regular and predictable. If she felt the first in the lower back, sweeps around the abdomen in a waveform, continues no matter what woman's level of activity is there, increases in duration, frequency, intensity with passage of time, and accompanied by show, that is a blood-stained mucus discharge, and associated with cervical effacement or cervical dilatation. So almost these 5 of the points can also be determined by the ANM or the auxiliary nurse midwife who is present at that particular level. So if the pregnant woman is in true labor, then you consider that the delivery is imminent, then give 1 dose of injection of dexamethasone as described in the box. So that's a 6 milligram intramuscular dose, and prepare for delivery and neonatal resuscitation. So this mother, it's difficult that she'll be able to transfer to a higher center. And if you feel that the delivery is not imminent, then you give 1 pre-referral dose of injection dexamethasone. Again, that's 6 milligram IM. If the patient is to be referred, otherwise complete the course. Tocolysis, delay of uterine contraction, is to be done under medical supervision. And then before referral, you can check the vitals, do a hemoglobin, sugar, urine exam, give antenatal steroid first dose, refer to the higher facility, and arrange transport and prepare a good referral slip. And if the referral is not possible, then you finish all the doses, do the routine test and BP, and arrange for delivery, resuscitation, and care of a preterm baby. So that's the standard SOP in a district level or a peripheral level. If a mother which comes with a imminent preterm labor between 24 to 34 weeks of gestation. So often in exam, the students fail to, tell the step that first a differentiation should be done between true preterm labor and a false preterm labor. Thereafter, most of the things are clear. So that point and that important assessment should not be forgot when you are, answering in the exams. And the second question often asked is that why betamethasone is not used. So we all know that that particular salt on which most of the studies are there, that particular salt is not available in India. And that's why we are not using betamethasone. We are using dexamethasone. And the ideal timing of giving the steroid should be 24 hours to 7 days after complete course of the treatment. If the delivery occurs, that will give the maximum benefit. The minimum amount of time required between administration and delivery. But however, there is no precise definition yet. Obviously, there are a lot of studies telling that even the partial courses do some benefit to the preterm babies. So even if there is no time to give the whole course, one should complete, the partial doses, whatever are possible. If you look at the meta-analysis, the benefits are that NEC reduction is by 54%, that is the maximum, IVH by 46%, RDS by 34%, mortality by 31%, and variable reduction in sepsis is also seen. The one word about the antenatal corticosteroids in late preterm. So this is what is recommended by the Indian government, that you don't give the antenatal steroids after 34 weeks of gestation, neither you repeat the doses. But later on, there were studies indicating that these babies between 34 to 36 weeks also had a higher incidence of these morbidities, and hence there was a huge trial, landmark trial, that is the ALP trial, which looked at antenatal corticosteroids in late preterms. And they found that there was a decrease in need for respiratory support, decrease in need for resuscitation at birth, and possible reduction in respiratory morbidity with minimal, adversities like neonatal hypoglycemia. And based on this particular study, the ACOG has now started recommending for a single dose, betamethasone in that particular group or the cohort where the gestation is more than 34 weeks and less than completed 36 weeks. So this is one more additional thing one should remember, that there is a role of antenatal corticosteroids, but then understand that most of these studies are done in the developed countries and the out and out benefit is not yet been determined in the developing countries. In fact, there are some studies looking at also a reduced advantage in developing countries. So currently this is not there in the operational guidelines of the Indian subcontinent, but this is on the horizon that we need to do more studies and see whether this particular thing is also effective at our context. So the magnesium sulfate in a woman with preterm labor, obviously it offers a neuroprotection. And now we have a Cochrane in 2024, which determines and places the conclusion as reduced cerebral palsy with the RR of 0.71. That's a reduction of almost 30%. And it was based on 6 RCTs and 6107 children. And number needed to treat was almost 60. And the confidence intervals was, not was out and out to the benefit. The death or CP was with the RR of 0.87. And again, the confidence interval between 0.77 to 0.98, 6 RCTs, and another 6,481 children. So it also offers some benefit if you combine both outcomes, that is the death and the CP. And if you take only the death, probably it has a comparable effect on the death. So if you look at the advantage of magnesium sulfate, specifically in babies who are born less than 32 weeks, we can see a 30% reduction in cerebral palsy, combined both moderate to severe. We can see some reduction in cerebral palsy plus death, both taken together, and a trend towards the reduction of death, but not a significant reduction of death. So based on this, you have the different guidelines by different bodies, like you can see the SOGC, Canada, the RCOG, UK, ANCP, Australia, ACOG, USA, and most of them recommend, gestational age below which the magnesium sulfate should be given is less than 32 weeks. And that is what we follow in India also. The dosing regime is 4 gram IV loading dose is given, followed by 1 gram per hour infusion up to 24 hours. And you can see the key findings are all the same, that there is a reduction in the neurodevelopmental delay or the occurrence of CP when this particular protocol is followed. So that's about, two very important interventions antenatally. And the student should be thorough about these interventions. How did they evolve? What is their benefit? What are their limitations? What's on the horizon? So I can say that on horizon, the lower doses of antenatal steroids, the use of antenatal steroids in late preterm. So these are some of the important things which are being investigated. And finally, one should also be able to explain what is the mechanism and how these molecules, they help in whatever neonatal reduction of outcome or the morbidity outcome they offer. And they are very commonly asked questions, both as OSCEs as well as during the Viva Voce when you present the history. So kindly look at these important landmark studies and how they translate into better neonatal outcomes. So I can go to the next OSCE if there are no questions. So I'll just see the chat box if there are any questions from anyone so that we can go to the next. Okay, so there are no questions as far as this.
No questions, sir.
Okay.
If there are any questions, I'll let you know, sir, after
Yeah.
each OSCE. Yeah.
Fine. So what I would request before we go to the second OSCE is that don't ask bits of answers. Try to take time of around 1 minute, as Dr. Swati said. Read all the questions which are there and answer to all of them in a single message so that it's easy for us to, see and discuss if any alternate or confusing answers are there. So with that, let's go to the second OSCE. So this is about the umbilical cord management, another important aspect of perinatology. A 28-week gestational age mother delivered vaginally with preterm onset of labor. The baby breathes well at birth and has some active movements, suggesting a good tone. The obstetrician asks about the umbilical cord management plan. So now there's a discussion on the umbilical cord management plan in a 28-week gestational age baby who sort of breathed very well at birth. So the first question is that what are the two benefits of delayed cord clamping in preterm neonates which are established? The second is what are the two contraindications of delayed cord clamping? Apart from baby being floppy at birth, that's not a condition here. So is umbilical cord milking advised in this case? So can that be an alternative or can that be advised in this particular case? What's the full form of PBCC? Have you heard about it? And if you can summarize, what is the NRP 2025 guideline on cord milking? So not on delayed cord clamping, but cord milking as to where you do cord milking. So those are the 4 sets of questions you have to answer as a single message in your chat box. And Swati can tell me when 1 minute is over so that we'll look at the answers.
Yes, sir. Sure, sir.
So try to answer all of them, whatever you know, don't answer in bits. So that's easy for us to, review. So I don't see any answers yet. I think they're taking some time.
All the candidates, you may start writing. Yeah, so they have started writing. Yes.
So, okay. So let me look at a couple of answers. So 2 benefits of delayed cord clamping in preterm infants are a reduction of intraventricular hemorrhage and reduction of need for blood transfusion, improved hemoglobin and iron stores. Other benefits often mentioned are reduction in NEC mortality, circulatory stability. 2 contraindications are placental causes, placental abruption, placenta previa, significant bleeding, cord problems, cord avulsion. And is the umbilical cord milking advised in this case? It's not advised because gestational age is 28 weeks. And the UCM in very preterm infants is associated with high risk of severe IVH. That's the reason. And PBCC is physiological based cord clamping. NRP 2015 cord milking, not recorded. I don't know. Not recommended. Okay. So similarly, there are some of the answers, which look at one or the other of these indications. I think overall, many of the students have answered correctly. So let's look at the answers. So as answered that the better hemodynamic stability and a lesser IVH are the important, outcomes of delayed cord clamping, which you can see the early outcomes. And as rightly said, that a placental cause or a cord prolapse or revulsion can be a contraindication where really you don't want to wait for the delayed cord clamping. And as far as the milking is concerned, there's no much evidence here, and so we don't do it. And PBCC is physiologically based cord clamping, where we wait till a physiological point when the pulsations are absent or a upper limit of 3.5 to 4 minutes. So that's called as physiological based cord clamping. And then RP says that milking can only be done in non-vigorous babies who are more than 35 weeks. You definitely do it. In 28 to 34 weeks, there is no evidence. You can use your judgment. And in less than 28 weeks, it's not recommended. So those are the, the recommendations by the NRP 2025. So the eighth edition for the newborn less than 28 weeks gestation, the umbilical cord milking is not recommended. That's the only statement which was given in the 8th edition, but now they have split that into 3 categories. So if a baby is not vigorous, then only you think of cord milking. And in that segment of the babies which are 35 to 42 weeks, you go ahead and it can be a reasonable alternative. In babies, between 28 to 34 weeks, there's no enough evidence. So it's an individual intellectual, assessment as to you want to use this method or not. But definitely in babies less than 28 weeks, based on the Anup Kataria study, you should not be doing the cord milking because it increases the chances of intraventricular hemorrhage. So this question is very important, and it will be asked in the exam both on the NRP station. It may be asked as a perinatal OSCE, or it may be asked as the NRP recommendations on cord management as a theoretical question. So kindly remember that milking is only indicated between 35 to 42 weeks. There is a very little evidence between 28 to 35 weeks, and there is evidence that you should not do it when the baby is less than 28 weeks. And all this is when the baby is not breathing, that is in babies which are not vigorous. If the babies are vigorous, the preferred modality is always delayed cord clamping and not cord milking. So this is a diagrammatic picture of what I was showing, that in a preterm vigorous, you can do a DCC, whereas in a non-vigorous, you can think of umbilical cord milking. But again, the preterm is divided into three categories. So between 35 to 42 weeks, you do cord milking. Between 28 to 30 this 5 weeks, you think whether you want to do or not, and less than 28 weeks, you don't do it. And as someone said that the cord problems, the placental problems, eversion, they're important, cord indications of not doing a delayed cord clamping. And in a vigorous term baby, you do a DCC, and in non-vigorous term baby, you can always do a umbilical cord milking. So obviously, the less than 28 weeks, you don't do it. So often when we ask students, what are the advantages? They generally club the advantages both in preterm and term, and that's what I saw even in the answers. But you should understand that some of the advantages are important for the preterm and some advantages are important for the term babies. So now let's divide this into two and see. So in the term babies, as one of your friends said, increase hemoglobin, reduce need for transfusion, prevents iron deficiency anemia during infancy, and better motor and social development. Whereas in the preterm babies, the IVH, the increased blood pressure and reduction in early neonatal shock, reduced need for transfusion and reduced mortality. So they are predominantly the advantages what you see in preterm babies. So kindly, when you answer, remember the advantages as advantages in preterm babies and term babies, rather than clubbing both of them, because the relevance changes with context to both of these. If you look at the contraindications, the maternal hemodynamic instability requiring maternal resuscitation, massive acute hemorrhage, that's the important example. Placental circulation issues like ruptured vasa previa, snapped cord, trauma cord vessels, hemorrhage from the baby. And there are some relative contraindications like HIV mother with a very high viral load, high antibody titers in mother for risk of hyperbilirubinemia and MCDA twins. So they are specifically mentioned by the ACOG. But for all practical reasons, the absolute contraindications are considered for delayed as contraindications to delayed cord clamping.
So there is a question from Dr. Jitendra on umbilical cord blood banking. Is it available in India?
So the umbilical cord blood banking, in fact, is altogether a different issue. But as far as the availability is concerned, yes, there are certain private companies as well as All India Institute of Medical Sciences who will bank the umbilical cord blood. But there are a consensus guidelines by the Indian Academy of Pediatrics. You can just go through it. You should not be doing it for all the mothers globally. There are certain indications where you do umbilical cord blood banking. And then you should understand and always follow up as to the stored blood, what is the viability. So every year you have to see that how many cells, both the hematopoietic stem cells as well as the mesenchymal stem cells, what viability they have. Because if they lose a certain degree of viability, then that will not be relevant when you want to use it. And second is that the yield should be always good. So unless you take 50 to 75 ml of blood, the yield is generally not enough to be used as a therapeutic interventions. But the most important question to answer here is that what are the indications of cord blood banking? And I think that can be taken as a separate question. Do we have that later on, Dr. Amit? We don't have it.
No, sir. No, sir.
Yeah,
That we have not included, sir.
So that you can go through the consensus guidelines and read that. And if the time permits, we'll take that in the end. Shall we go ahead?
Yes, just a small question from Dr. Gaurav that what about initial steps in non-vigorous infants, whether they should be done on mother's abdomen or radiant warmer?
So you're asking about the 2025 guidelines?
Yes, sir.
Yeah. So if you are doing the if you're delivering a baby, so the initial steps are done on the mother's abdomen only. That is what the Indian guideline says. But as far as the American Academy of Pediatric guidelines says, you can shift these babies who are preterm to the warmer and do the initial steps. So that guideline has not yet currently changed. So the issue is that all vigorous babies in the Indian NRP 2020, we were doing and we are doing the initial steps on the mother's abdomen. But because that qualifies, the preterm baby qualify as an indication for initial steps, as far as the NRP is concerned, let it be 2025 or 2020, as laid down by the American Academy of Pediatrics, these babies have to go to the warmer. And also the ILCOR guidelines say that if possible, these babies should go to the warmers. If they are vigorous in warmers and you don't, they're okay after initial steps, they can come back to the mother. So that loop can be completed, but that small difference is there between the Indian recommendations and the American Academy of Pediatric recommendations. Does that help you? Okay.
Yes, sir. Yes, sir. We can go ahead, sir.
Yeah. So let's come to the third OSCE. So this is a 22-week pregnancy and has a fetal echo done, and that fetal echo shows hypoplastic left heart syndrome. So at 22 weeks, this mother underwent a fetal echo and that showed a HLHS. There are no other anomalies detected. Parents are anxious and request a detailed counseling. So what advice you will give to the family, termination or continuation of pregnancy? That is the first question. Up to what gestational age the opinion of medical board is not required by the current guidelines of the MTP 2021 recommendation? And what is the limit of gestational age for 1 RMP and 2 RMP respectively under the same amendment of MTP Act? And how many categories exist where extended termination up to 24 weeks can be advised? Name any two of them. And what is the minimum composition of a medical board? So these questions revolve around the MTP Act and the amendment of MTP Act, which is very important for all the neonatologists to know. And hence the questions are, framed on that particular act only. So I request all the students, to go back and pull out that MTP Amendment Act. It's hardly 5 or 6 pages and read that thoroughly because this may come as a community medicine question. It may come as a Viva OC question. It may come as a counseling question. So at any of these places in your exams, this may come, and it's very important for your practical, neonatology practice later on. So we'll give a minute for people to answer, and then Swati, you can tell me when to open the
Yes.
answers. Okay, so this says continued pregnancy as there's no other defect, medical board not required till 20 weeks of gestation. HLHS is a severe CHD, counsel regarding continuation versus termination, RMP less than 20 weeks, and 2 RMP 20 to 24. Extended allowed in 7 special categories. I think this answer seems to be quite appropriate. And medical board, 4 members. Okay, so 1 member is more here. Yeah, so I think Nikhar, Somani, and the group has answered quite well. So let's look at the answers. So I'm just putting some slides on the MTP Act, which was earlier and what is now. So in the existing act, the requirement for opinion of 1 provider for MTP is up to 12 weeks, and the requirement of opinion of 2 providers is between 12 and 20 weeks. So what has been amended now is the requirement for opinion of 1 registered practitioner is up to 20 weeks. And the requirement of 2 registered medical practitioners is for pregnancy of 20 to 24 weeks. So basically, the earlier MTP Act limited, up to 20 weeks and had one RMP for less than 12 and one RMP for 12 to 20 weeks. But now, for all that was recommended in the earlier Act, one RMP is good enough. But if you want to go between 20 to 24 weeks, then you need 2 RMP. And that was the reason at the footnote why this was taken. Okay. See how. So earlier the MTP is permissible beyond 20 weeks only when it is immediately necessary to save life of a pregnant woman. And now the enhanced upper gestational age limit has been 24 weeks, and certain special situations or categories of women have been mentioned. And as Dr. Nikar said that there are around 7 special situations, he's absolutely right. There are 7 important special situations where you can take a decision between 20 to 24 weeks. They should be there along with the 2 RMPs, to enact the act. So one is that the survivors of sexual assault, rape, and incest, minors, change of marital status during the ongoing pregnancy, widowhood to divorce, women with physical disabilities, mentally ill women including mental retardation, the fetal malformation that has substantial risk of being incompatible with life, or if the child is born, would suffer from such physical and mental abnormalities to be seriously handicapped. So our case comes in this particular 6th special situation. And as he is 22 weeks, we can take a decision to terminate this baby. And women with pregnancy in humanitarian settings, disaster and or emergency situation as declared by the government. So these are 7 special situations where you can go up to 24 weeks just without a medical board and take the opinion of 2 RMPs. Sorry. So beyond 20 weeks, nothing was allowed earlier, but now the upper gestation will not apply in case of pregnancy with substantial fetal abnormalities diagnosed by the medical board. So if you want to go beyond 24 weeks, then there has to be a recommendation by the medical board. And these medical boards are established in various hospitals. And the minimum composition of a medical board is 3 people. I think it was answered as 4, but that 4 is very the well. But the minimum composition is 3 people, out of which there should be 1 gynecologist or obstetrician, 1 pediatrician, or nowadays where the neonatologists are there, they are in the medical board, and 1 sonologist or radiologist. And out of these 3 people, at least 1 should be a woman member, and 1 member should be from the government hospital. So there are some of the recommendations of a medical board. And the norms of the RMP's opinion is required for termination of pregnancy at different gestational age. We already discussed that when we tell RMP, then you should be a practitioner who holds postgraduate degree or diploma in obstetrics or gynecology, or who has a 1 year of practice experience in obstetrics or gynecology. And then along with that, a medical board is important when you go beyond 24 weeks of gestation. So again, dear friends, students, this is very important aspect which generally we miss for as a part of our curricula. So one should always know that what does the MTP Act define, and especially what a medical board, when a medical board is needed, what is the composition of medical board, what are the considerations in a medical board that warrant a medical termination, and when you required a second RMP to authenticate when you want to terminate. Along with this, there is another act. Maybe we are not able to put an OSCE on that. That is a PNDT Act. So I request everyone to look at these 2 important acts as far as the perinatology is concerned. One is the MTP Act and second is the PNDT Act. And even as a practical awareness, when you are practicing neonatology, these 2 acts are very important. So if there are no questions, we can go to the next OSCE.
Yes, sir. Yes, sir.
So let's come to the 4th OSCE. So a 24-year-old 30 plus 2 week gestation is referred to with USG findings of ascites, bilateral pleural effusion, scalp edema. Okay. And the MCA PCV is elevated, the maternal blood group is O positive, and the ICT is negative in the mother. What's your diagnosis? what are the common causes of diagnosis in first and second trimester? What is the commonest cause of diagnosis in later pregnancy? And 3 investigations you want to do antenatally, mostly in such cases, and mention 2 important infective viral causes which can cause this condition. So maybe we'll wait for a minute for answers, and then we'll go ahead with the answers. Yeah, so many have mentioned hydrops, but what's important is that hydrops, you have to distinctly tell it's immune or non-immune. Yeah, we have one answer again, telling that it's a non-immune hydrops fetalis. And it just says chromosomal anomalies. I don't know whether that's during the first initial days of pregnancy or later. MCA, PCV. Okay. Yeah. So there are some answers with some bits were responded. Okay. So I would also suggest that if you have similar answers at the top, you need not answer them. Shall we go to the answers? Yeah.
Yes.
So obviously, there's a condition where it tells you that the baby is hydropic, and the information that the ICT is negative and there is no AB or RH incompatibility says that mostly the cause is non-immune hydrops. And the chromosomal and genetic causes are very important, which predominant in the early times, and the cardiac causes will predominate in the later, almost 33% or 40% of them. So all cases, as we know that the cardiac is a very significant issue. So the fetal echo is recommended, a torch profile is indicated, and MCA Doppler and a fetal karyotype or a microarray. So these are the 4 minimal investigations one can do antenatally. So grossly, we are looking at, infective causes, we're looking at cardiac causes, we're looking at, non-immune anemic causes, and we're looking at chromosomal causes. And some of the infective viral causes which may cause non-immune hydrops are the B19 parvovirus, CME, herpes type 1, and rubella. So you can see these are the non-immune hydrops fetalis etiologies. So as I was telling that the cardiovascular, dominant, then the chromosomal, hematological, infectious, and miscellaneous. And many times, almost 15 to 25%, you don't find what is the cause. But as you do more and more extensive investigation, that particular segment of unknown causes will come down. And in best of the centers like, Cincinnati Center, which does a very good fetal medicine, these unknown causes will be hardly like 10%. And then you have other sets of causes which are slightly less common, which are given on the right side. Now, if you look at the infections which can cause, non-immune hydrophytalis, so they can be viral, parasitic, spirochetal, and bacterial. So they are dominated by the viral infections, as we said in the last answer. That's the human parvovirus B19, cytomegalovirus, other herpes viruses, but predominantly type 1, which causes recurrent hydrops actually. So if you get an MCQ like telling recurrent hydrops, that generally is focusing on herpes simplex, herpes virus type 1. Coxsackie and rubella. Parasites like Toxoplasma and Trypanosoma also may cause. Spirochetes like Trypanosoma pallidum and Leptospira. And bacterial, the Listeria. Again, a very important MCQ bit for DM entrance. If you look at the cause of non-immune hydrops as a bacterial, then Listeria monocytogenes is very important. So so these important infective causes one should know. Also, at times, you may have an OSCE which is asking that what are the inborn error of metabolism that can cause non-immune hydrops. So we didn't put that question, but that's also a very important thing what you should know, that what are the inborn errors of metabolism that can cause, fetal height drops. So these are some of the important things we should remember about non-immune height drops. So how do you work up for a non-immune height drops? You do a detailed ultrasound, including fetal echocardiography, as mentioned in the last slide also. If you find that, the heart is structurally normal and there are no arrhythmias, then, do a MCA Doppler. If the MCA Doppler is normal, then you do amniocentesis and do a karyotype. So basically, we are looking at the cardiac first, we're looking at the anemic later, and then we're looking at the chromosomal. Now, if you find that the MCA Doppler, you find an anemia, then you do a fetal blood sampling and plan for a transfusion, and also then look at all these infections, which basically have a mechanism of reduction of, the hemoglobin and the stress on the heart. And if you find a structurally abnormal heart, then you do an invasive prenatal testing, karyotyping, CME, toxoplasmosis, DNA testing. So that's a general approach for how you approach a non-immune height drops. And some of the therapies which you can do for non-immune height drops antenatally, like you can administer maternal transplacental cell antiarrhythmic medications in case of supraventricular tachycardia. You can do a fetal blood sampling followed by IUT in case of fetal anemia secondary to parvovirus infection. And a needle aspiration can be done if there's a fetal hydrothorax, chylothorax, or large pleural effusion, which is causing because of bronchopulmonary sequestration. CPAMs also can be handled, basically the macrocystic types. And triple TS and TAPS, you can do a laser ablation and placental anastomosis. So these are some of the antenatal interventions that revolve around, management of height drops. And mostly, if you see all these antenatal interventions, the moment the baby goes hydropic, in these particular situations, that's a out and out indication for any antenatal intervention, because then the time is very less. So if there are no questions, we can go for the next.
Yes, sir. No
Yeah.
questions, sir.
So then let's go to the fifth OSCE. A 26-year-old G2P1L1 30-week gestation mother has a blood group which is O negative. She's ICT positive. Anti-D titer is 1:64. And the previous baby, there's a history that he required exchange transfusion. What is the critical anti-D titer we generally consider, and how to monitor this baby antenatally? Basically how to monitor the mother or the baby antenatally. What are the indications of IUT or intrauterine transfusion? After delivery, how much anti-D should be given to mother in this particular case? And what is the fall of hemoglobin every day after you give the first IUT? So we'll give a minute and then come back. Okay. So some of the good answers from the last, discussion about the IEMs causing hair drops. Then we have 1:16 and monitor antenatal with maternal antibody titer, MCA PCV, and MCV more than 1.1 MOAM. That's the correct answer. And somebody has given the dose of anti-D, but you should understand that here the ICT is positive. And then 1 gram per day fall. So we look at the answers. So that's correct that 1:16 is considered to be good enough as a criterion. And as rightly answered by one of your friends, that the MCA Doppler more than 1.5 MOM with fetal anemia becomes the indication for IUT. But you should also understand that many times we do IUT at a MOM of 1.3, 1.4 also, provided you start having the features of high drops. So without high drops, there's a very good criteria that if it's more than 1.5 MOM, you can do a ICT. Fetal PCV was less than 30 and hemoglobin of less than 10. So that's very important. And anti-D prophylaxis is not required here, as I said, because the mother is already sensitized and this will not help. And around 0.2 to 0.6 is the range given. So I've just written 0.4 gram of hemoglobin falls per day when you give the first IUT, and this changes as you do multiple IUTs. So the prophylaxis of anti-D is given at 28 weeks as 300. Somebody mentioned that dose. Post-delivery 300 if the baby is RH positive. And any sensitization event after 12 weeks, you can just give 10 microgram. But this baby, the earlier baby also had exchange transfusion. So the mother is already sensitized. So in this case, I think the anti-D has no role. So this is a schemata of how you manage this baby. You determine the RH status of the mother. In case of the negative mother, you determine the RH status of the father also. If RH negative woman with RH positive husband, you perform a ICT titer. If the titer is negative, you repeat it every 4 weeks. Give anti-D 300 as stated between 28 to 32 weeks and repeat anti-D after birth within 72 hours. If the ICT titer is positive, but it is less than your criterion, that is less than 1.1:16, then you repeat titers every 2 weeks and deliver at normal time. No anti-D prophylaxis is needed. But if the anti-D titers during this monitoring, if they go beyond 1:16 dilution or they are more, then you monitor every 2 weeks. And how do you monitor every 2 weeks? You do a fetal USG 20-week onwards and MCA PCV and look for features of hydrops. Now, if you find the features of hydrops, then you perform chordosynthesis and immediately go for IUT, as I said. Then you need not look at the criteria of MCA PCV of 1.5 MOM or more. And if there is no hydrops and the MCA PCV of 1.5 MOM or more is there, you repeat the MCA PCV after 1 week. And if the MCA PCV is 1.5 MOM or more still persisting for more than 5 to 7 days, then you go for IUT and then deliver the baby at 35 weeks or later. So that's the normal schemata we follow. In the postnatal management at birth, if there are no signs of severe anemia, birth, hydrops, or there are signs of severe anemia, hydrops, you shift the baby to NICU. And cord blood group and DCT, hemoglobin, bilirubin, blood film, and platelet count should be done. The platelet generally are less when the IUTs are done. And if you find the cord PCV is more than 30 and bilirubin is less than 5, then a repeat hematocrit bilirubin can be done and the baby can be monitored. But if the cord PCV is less than 30 and the bilirubin is more than 5, then he needs a DVET. And many times when you do IUT, you'll not find bilirubin that much, but you may find that the hematocrit is less than 35. So you can do a partial exchange with 50 ml per kg of Paxil, or there's a formula also to calculate. So that's like a top-up transfusion you give. So this is the immediate postnatal management of these babies, what you can do. And if obviously you have a lot of pleural effusion which is affecting the ventilation of a baby, you can go for a drainage also. So can we go to the next?
Sir, somebody has asked that why is anti-D not required in next pregnancy? This is the question from one of the candidates.
So in a sensitized pregnancy?
Yes, sir, yes.
So I can ask back that why you want to give anti-D in a
Right.
sensitized pregnancy. So once the pregnancy is sensitized, that means there are already the antibodies which have armored the RBCs of the fetus, and then what anti-D you give have no place to sit on. So they'll actually not prevent anything. And that's why if the sensitization is there, then we don't give the anti-D. So it's a very obvious situation where you don't give anti-D. So let's go for the next question, that is the sixth. Maybe we can take one or more because we started late, so we cannot do 2 questions. We'll do only 8 and stop. So this is a question of multiple pregnancy. There's a 28-year-old primigravida who's 32 weeks of pregnancy and scanned to have MCDA twins, no discordance. The fetal weight is 1.3 and 1.4. The Dopplers are normal. So the question 1 is when to deliver these twins selectively. Second is what are the complications of MCDA twins, and name the staging related to complication of twin pregnancy, especially in the MCDA. What is TRAPS and how do you diagnose TAPS? So the fifth question is different from fourth. Fourth is what is TRAPS and how do you diagnose TAPS? So we'll give a minute for students to answer and then come back to our answers.
Sir, maybe 10 or 15 minutes more you can take, and maybe with little short discussion we can have the last two questions also, or maybe just question and answers to.
Yeah, then the organizers have to take a call.
Yes, sure, sir. That will be great. I think we can take the questions
Yeah.
and maybe we can cut short on the discussion part, sir.
But because it's a teaching and learning exercise,
Right, sir.
I don't agree with starting late even by a minute.
Right, sir. I totally agree, sir.
So let me see the answers. The first answer, it says that there's no difference as per obstacle indication more than 37 weeks, and then some complications are mentioned like triple TS, taps and traps, Quintero staging. So mostly that's correct. And then what is traps? I don't have an answer. Transfusion-related arterial perfusion. Okay. Okay. So I think 3 or 4 questions have been answered by most of the students. Let's see the answers. So 36 to 37 weeks would be good enough. I mean, nowadays, if you look at the ACOG criteria, 37 weeks is not an indication for CS. So they would wait up to 41 weeks and 42 weeks. So in twin pregnancy, maybe that would be relevant, that 36 to 37 weeks, because after that, the chances of IUGR increase drastically. Then you have the TTS, TAPS, and discordant twinning, which one of your colleagues answered. Quintero staging is the staging which is used for twin-twin transfusion syndrome, and TRAPS is twin reverse arterial perfusion sequence. And intertwin hemoglobin difference of more than 8 and a retic count ratio, donor to recipient of more than 1.7, tells you about the TAP, because here the main issue is not the difference in the hemodynamics, but the difference in the hemoglobin. So the generally the delivery in multiple pregnancy, as the ACOG recommends, is that if you have a DCDA, they go up to 38 to 39. DCDA isolated growth restriction can go up to 38, and MCDA twins uncomplicated 34 to 38, and MCDA twins with isolated growth restriction up to 35. So that's what they indicated. But the major thing what you should understand is that in MCDA situation, 37, 38 weeks is generally the time beyond which generally the pregnancies are not continued. The complications of MCAD twins may be like twin-twin transfusion syndrome, where the blood is transferred from the donor to recipient. There may be a selective FGR, where unequal sharing of placenta is there. There may be a twin anemia polycythemia sequence, that is a TAPS in the late term baby, and twin reverse arterial perfusion trap, which is generally rare. And about this, you may have obviously preterm delivery and IUPT demise. So if you look at these 3 conditions, which generally are asked out and off whenever you get a twin case or in OSCEs, the TTTS is a volume imbalance. So you'll have polyhydramnios in one of the twins and oligo in other twins. Whereas TAPS is a chronic RBC transfusion. So you'll have a large chunk of hemoglobin difference. And the TRAP is a reverse arterial perfusion. So you'll have one twin, which has also a malformed cardiac twin will be there. So you should understand how to differentiate between these 3 conditions. And many OSCEs will revolve around, what is the core mechanism behind these 3 situations. So this is the Quintero staging. In stage 1, you see that there's imbalance between distribution of amniotic fluid with donor twin sharing less than the recipient. In stage 2, what happens is similar to stage 1, but the bladder now you can see that of the donor twin is not visible with Doppler. And in the stage 3, you have the absent or reverse umbilical arterial flows, reverse ductus venosus flows, and pulsatile umbilical venous flows. And finally, you have a demise, whereas, one or the other twin presents with a fetal hydrops in stage 4. So this is a classical Quintero staging. And as you go up on the staging, I think the prognosis, deteriorates by almost 20% for each stage. So if there are no questions, we'll go to the next OSCE.
Yes, sir.
No questions, sir.
Okay. So here we have a question on a national program. That's again important and ignored by most of them. So you're posted as a consultant neonatologist in district hospital. So a lot of people will be posted initially when they're serving the bond period, and the hospital administration plans to implement a Lakshya program. So what's the full form of Lakshya? What areas of hospital does it cover? What are the key objectives of the program? And how are Lakshya medals achieved? And what are improvement dimensions in Lakshya? So these are some of the programs with questions which evolved around very important aspects of Lakshya. Okay. So I think very minuscule of answers here. But all of them know that something related to labor room quality. Okay. So let's go to the answers. So the Lakshya is a labor room quality improvement initiative, and it focuses on labor room, obstetric OT, immediate newborn care. So these are the domains where the Lakshya revolves around, and its main objective is to improve a labor room and obstetric OT reduction in maternal and neonatal mortality. And you have certain medals. So there are required. If you complete by more than 90% score of the requirements, then you get a platinum medal. If you complete 80%, then you get a gold medal, and more than 70, you get a silver medal. And processes are divided broadly into structural and process changes. So that's the Lakshya which was introduced in 2017 by the National Health Mission and the Ministry of Health and Family Welfare. And the objective was to reduce preventable maternal newborn mortality, morbidity, and stillbirths. So it's looking more like you prevent things rather than treat them once they are done. The goal is to improve quality of care provided to pregnant women in labor room and maternity operation theaters. And government or medical colleges, district hospital is important, sub-district hospital. Everyone is now getting, Lakshya certified. So if you look at the components, you have a component of assessment where a baseline assessment is done for the labor room, standardization, MNH toolkit, and NQAS. So once you are posted in one of these district hospitals, you will be given this, the whole responsibility to get this assessment done, because you will be a, qualified neonatologist when you go there. So you should know that how the toolkits should be used, MNH toolkits. And then you look majorly at the two domains, as I said, the structural improvement and the process improvement. As far as the structure is concerned, which we tell as the H out in the inputs, where we look at the labor room standardization, human resource setting, and labor room certification. And the process are the quality circles, the rapid improvement cycles, and improvement maternal, stillbirth, and newborn health indicators. So, these are mainly the hospital related issues. If you look at the structural improvement, but the process improvement, we neonatologists and the team have a very important role here. So you should be very clear as to what quality circles you will form, how you will do, rapid improvement cycle campaigns. So there are different ways how you can do that. The 5I method, the, PDSA cycles, the fishbone analysis. So all those things. And that is how this is one of the very important quality initiatives which are taken, first quality initiative taken by the government in 2017. So if you come to the next OSCE, again, it's on a national program where you are posted in a district hospital. Mother of the preterm baby asked whether her delivery and newborn care are covered under a government scheme. So now it's about what subsidies does the government offer to these mothers who are coming pregnant to the hospital, and one should know that what are these subsidies. So what is the most important program which revolves around the subsidies, the Suman. So you should know what is the full form of Suman and what's the main objective of Suman, till what age in newborn covered under Suman, and what are the 4 important services that are given free under Suman, and what is the initiative to one who reports maternal death in this program. So if there's a maternal death under Suman and somebody reports a maternal death, he gets an award. So what is that award? So, okay, so we have an answer as Surakshit Matritva Shashwasan. Okay. Zero presentable mother and newborn death. Okay, so that was actually an objective of Lakshay. Yeah, sorry. Okay. So let me quickly go to the answers because we're not getting much answers here. So Surakshit Matritva Ashwasan is the correct, full form of Suman. And here it looks at a free maternal and newborn quality service and a zero preventable maternal and newborn death. So that preventable word is very important. That we want to bring it down to 0. And the newborns are covered till 6 months of age. And the important, subsidies or free of cost services which are given are, transport, complications, cesarean sections, and also all medications for prevention of transmission of HIV. And if you report a maternal death under this program, you get an incentive of 1,000 rupees. So this is what is Surakshit Matritva Ashwasan, promoting zero preventable maternal and newborn death. and it gives an incentive of 1,000 rupees to a person who first reports a material death. So you can see the important objectives are to eliminate and zero out, eliminate all the preventable causes, zero out all the pocket expenses, and give a dignified and respectable care. So this dignified and respectable care also is very important. It gives a high satisfaction index to the people coming to government hospital, and timely access and quality of health services. The key features are, a lot of free services, zero expense guarantee, grievance redressal, and respectful care. Services for sick newborn are free treatment, special newborn care units, transport, diagnostics. Implementation of a lot of programs which are run by the NHM, and obviously there are challenges for this, but it's a very overarching and ambitious program by the government. So this is a guarantee charter which is stated under Suman. There are a lot of services which you can see. 4 of these services you already said which are free of cost. So the vaccination is free, the postpartum planning counseling is free, and the services for the maternal child transmission is free. The LSCS is free. So all these things are free under this particular program. Coming to the next, OSCE. So identify the graph which is shown, on the left-hand side. What does it indicate? And it's used for assessment of antenatal fetal well-being. And beyond what gestation does this method used? And where can you measure the STV? Let me tell the full form. That is a short-term variability. And how much FHR variability is considered as normal, and define variable acceleration and its cause. Sorry.
So that question page, we'll have to just go back 2 slides. So the questions we cannot see now.
Oh, this is already, I think
Next
it's,
one has come, sir.
yeah. Okay.
Yes.
I don't know, how did it jump? Okay, so there's some, answers also which were flashed. So CTG after 28 weeks is one answer we have. Okay. So let's look at the answers. So obviously this is a cardiotocograph, and as correctly answered by one of the students, it is done beyond 28 weeks of gestation. But if you look at the STVs, this is only possible when you use a computerized CTG. I'll also put up some difference between computerized CTG and a conventional CTG. And 5 to 25 beats per minute variability is acceptable. And fall in a FHR with no relation to the uterine contraction is generally defined as a
Variable.
acceleration, and umbilical cord compression is the most common reason. So this is how it is monitored. You have, contraction monitor sensor and one fetal rate monitor sensor. So they're basically 2 sensors, and you get this particular tracing what was showed. So the approach to CTG, by bravado says that you define the risk, you look at the contraction, then look at the baseline rate, look at the variability, acceleration, deceleration, and then put an overall comment. So that's just a simple way how you actually read the CTGs. So if you have this as a spotter, I think this is one thing you should be using. So you may have that as spotter on your Viva table. So kindly you first ask the risk of the mother, see that how frequent the contractions are, declare what is the baseline rate, and then look at the variability, and then finally tell the pattern, one of the twos, and then overall comment. So that's very important how you read. So this is early deceleration. So you can see that the deceleration starts with the uterine contraction and begins to recover when the contraction stops. So basically it's very much related to the contraction, and this is mostly physiological. And if you fall a rapid fall in the baseline fetal heart rate with variable recovery, so that's a variable deceleration. And you see that in umbilical cord compression. But what is more worrying is, the late deceleration. So where, the contraction finishes and the deceleration starts and it does not recover till the contraction again picks up. So that particular may indicate a fetal distress, so which is very harmful. So you have 2 types of, CTGs, mainly the conventional CTG and the computerized CTGs, which is now available in some of the hospitals. But the short-term variability in STV measured numerically in computerized CTV only. It's not measured in the conventional CTV. The objectivity also is less as far as the subjectivity is less as far as the computerized CTG is concerned. It has a very good high reproducibility, And there are analytical patterns which are given by the computerized CTG, and also it's very less dependent on operator expertise. So there's more and more a move to move the computerized CTG to the district hospitals, so where there are no experienced people, actually. So this computerized CTG may be a more relevant thing to do rather than the conventional CTG. So one should know what are the differences between these two CTGs. So I'll come to the last OSCE. So we'll finish exactly in an hour. So the OSCE 10 says, it's a 39-year-old primary gravida IVF conceived, is admitted with leaking PV at 30 weeks of gestation, has an AFI of 4, Doppler normal and CTG is normal. So what decision do you take for this baby? Do you want to do LSCS or not on this baby? 2 days later, if the Doppler study shows that the baby starts to have an AEDF, that is absent end-diastolic flow in the UA Doppler, should an emergency LSCS be done? And after that 2 days, again, he has AEDF, that is a reversed end-diastolic flow. I think that R is missing. So shall we deliver that baby now? What is CPR as far as the antenatal surveillance is concerned based on the Doppler findings? And what is an abnormal PI in umbilical artery and MC? So it revolves around, the Doppler reports you must be seeing during your day-to-day practice. And it's very important that we understand what these reports mean and what they translate into as far as the fetal high risk or the fetal outcome is concerned. So let's see if there are any answers for this. So it says that you don't do SCS and don't do SCS if the ADF is there. And then you do SCS if it's converted to REDF. And the CPR full form is cerebral placental ratio, and okay, umbilical more than 95. I think that's fair enough. But then we also need to know how CPR is calculated. And okay, fine. So let's look at the answers. So obviously you don't do a CS just because of that. And then, but you will have to give antidiarrheal corticosteroids and magnesium sulfate. ADF is never an indication for CS, but it's an indication that you aggressively monitor the mother. But then REDF can be an indication. Cerebral placental ratio is, PI of MCA by PI of UA. And UA PI of more than 95 percentile and MCA PI of less than 5th percentile is generally a bad, and then an indication of some problem, fetal distress. So if you're looking at the umbilical artery, which is perfusion of fetoplacental ratio and umbilical arteries on that side, so you interrogate some of the important, arteries in the on the fetal side. That is the middle cerebral artery, the aortic isthmus, ductus venosus, and umbilical vein. And on the maternal side, you interrogate the uterine artery. So these are the main vessels where the Dopplers are done. And if you look sequentially how the fetal distress changes these patterns, you can see that first the umbilical artery PI increases to more than 95th percentile. Then the CPR ratio, the MCA, becomes less than 5th percentile. Then you'll have a AEDF, then you'll have a REDF, AEDF and absent adductus. Then at the aortic isthmus, the ductus venosus, the PI may increase to more than 95th percentile. Then you have REDF, pulsatile umbilical vein, and then the biophysical abnormalities ensue. And finally, there will be fetal acidemia and stillbirth. So if you look at the stage STG based management of IUGR, so it stages the IUGR based on the criteria. So if it's a severe smallness and mild placental insufficiency, like estimated weight of less than 3rd percentile, CPR of less than P5, UA of more than 95, MC of less than 5, and UTA PI of more than 95, then what you do is you do a weekly monitoring and then deliver at 37 weeks. And if it's a severe placental insufficiency as indicated by reverse AOI or UA AEDF, then you do biweekly and deliver it at 34 weeks. And if it's a low suspicion fetal acidosis, almost impending acidosis, with a UI persistent REDF and DV PI of more than 95, then maybe you have to repeat every 1 to 2 days and deliver at 30 weeks. And if it's almost a fetal acidosis with a DV reversal 4, then maybe 12 hours and earlier delivery may be indicated. So that is how you manage these babies who have a very bad antenatal surveillance or who have risk of fetal hypoxia. So while measuring, basically these ratios are based on your pulsatile flow. So you can see that this is systolic and this is diastolic. So if you look at the systolic velocity on diastolic velocity, that gives you the SD ratio. The RI is systolic minus diastolic by systolic, and PI is systolic minus diastolic by the average. So you can see what is S, what is A, and what is D. So the normal umbilical arterial waveform is like that. When you see that the artery with increased resistance, you will start seeing this, diastolic flows which are not coming down. Then umbilical artery with absent end diastolic flow, where the flow completely is absent during diastolic phase, and umbilical artery with reverse, where you'll find during diastole there is some reversal of flow. So that is how it progresses. And the middle cerebral artery, that if the baby is more and more compromised, it tries to spare the brain, so it increases marked, blood supply to the brain even the diastolic phase, and that reduces the MCA-PI to less than 5th percentile, which is very obvious here. The CPR is MCA-PI by UAPI. It is the ratio of middle cerebral artery pulsatility index over umbilical artery pulsatility index, and if it is less than 5th percentile, it's an important predictor of poor placental function and FGR in late trimester. So in early trimester, we don't look at the CPR, but in late trimester, generally beyond 30 weeks, this is a very important predictor. So maybe I'll hand over now to Dr. Amrit.
Thank you, sir.
Yeah, so we have exceeded around 5 minutes, but sorry for that. You can catch up and finish
No
off by.
problem, sir.
Okay.
So I'll try to finish early. So I'll share my screen here.
Yeah, I'll just unshare my screen.
Yes, sir.
Yeah, please
Before
go.
I start, thank you organizers for inviting me as a faculty, and thank you for posting me with Ashish Jain sir. Because sir, you have given a great framework of questions, and then working was little easy. 10 questions are there. We'll try to finish in 40 minutes maybe, because they are mostly the practical questions. So is my screen visible?
Yes, your screen is visible. The presentation is not yet, Amrit.
Okay. I will just stop again and share. Is it visible now?
Yes, it's visible now.
Okay. So only one question will come at a time. You can answer alongside that chat box. I'm not able to see on the right. So any answers? Okay. So first. Okay, this is the first question. 28-year-old G2P1 delivers at 38 weeks. This is hepatitis B is a common scenario. Hepatitis B positive mother delivers a baby, and you being the doctor on duty or the neonatologist, so gynae people is asking questions. So when you go to the labor room, what additional maternal blood investigations you want to know that will predict the vertical transmission to the newborn? That will, the risk that will increase the risk of vertical transmission to newborns. Any other blood investigations you want to know in mother?
Yes, they are answering in the chat box, Amrit. Already they have answered. You can see the chat box down. It is.
This is okay. So viral load correctly answered. Hepatitis B, HBeAg, and viral load. Very good. So these are the two investigations. So what are the The risk of transmission is if hepatitis HBeAg is positive, what are the risk of transmission? How much percentage increase? Is slideshow coming or the full screen is coming?
Only the slides are coming. The slideshow is not visible.
Oh. Just 1 second. Yeah. If hepatitis E is there, then around, okay, we'll see the answers. Okay, the next question is, what will be the immediate plan for the newborn after delivery? Hepatitis B vaccine and immunoglobulin within 12 hours. That's correct. Immunoglobulin and vaccine, that's right. Actually, the problem happening is when I come to Zoom, then this presentation I'm not able to see. Okay. So the last question is, at what age to investigate for the viral markers in the baby? So most of the answers are correct. We'll just see the answers. Answers you are able to see?
Yes, yes.
Slide is
Is
visible
it?
now.
It's
Okay.
visible. Yes.
So hepatitis HBeAg and the viral DNAs are most other important investigation we want to know, because if HBeAg is positive, there is 70 to 90% increase in transmission. And correctly answered, hepatitis B vaccine and immunoglobulin we have to give. Some guidelines say 12 hours, some say 24 hours. So at least within 24 hours, we should give these two things. And by 9 months, then we have to see the blood reports in the newborns. So this is just a WHO flow chart, which mostly is the maternal part. That if HBsAg is positive, and viral DNA or HBeAg, if these two are positive, viral DNA high means more than 2 lakh international units per ml, and the HBeAg if positive. If both are positive, then mother mostly will have to take antivirals also. Anyway, the our part is that we have to give hepatitis B vaccine and the immunoglobulin at least within 24 hours. So the risk factor is, if it is negative, it is less than 10%. If it is positive, then it is 70 to 90%. And if the viral load is more than 2 lakh, there is again increased risk of transmission. The management correctly answered 9 to 12 months. We have to investigate HBsAg and antibodies. We have to see if HBsAg is positive, then that baby is infected, and then we have to follow up. If the antibody titer is less than 10, that means the baby is, if HBsAg is negative and antibody is less than 10, that means the baby is uh, not infected, but the antibody titers are less, so we have to revaccinate with the 3 doses. And if antibody titer is also more than 10, then that baby is immunized, nothing has to be done. So the next question is again infection. Chickenpox is again a common asked questions and sometimes seen also. So 38 weeks, baby delivered. The mother had rash 2 days before the delivery, and it's a varicella infection confirmed case. So the question one is, at what gestation age is maternal varicella infection associated with highest risk of congenital varicella syndrome? मतलब what gestation, if mother gets varicella, there is a high risk of congenital varicella syndrome. First trimester. Someone answered first trimester. Within 16 weeks. Okay. 5 days before, 2 days after, first trimesters. Okay. Chalo. I'll show other questions also. If that will take less time, I'll show all the questions. So these are the other questions. And at what time maternal varicella during the pregnancy, the risk of transmission is high. It's the maximum risk of transmission from mother to child is maximum. That is what time? And first question was maximum chance of having congenital varicella, what time infection? And then what will be the management of the newborn? And can breast milk be given to the baby in this case? So 2 days before, 5 days after, some said 5 days before, 2 days after. Other question is management plan and breast milk. Management VZIG, but VZIG sometimes we don't get. Then the other option, breast milk can be given if no lesions are the best. IVIG. IVIG. Separate the baby and the mother until rash disappears. IVIG, VZIG. If no rash, IVIG. So most of the answers are correct. So the answers are first 20 weeks, mostly 13 to 20 weeks. If mother gets varicella, the child develops congenital varicella syndrome. But the highest risk of transmission is 5 days before to 2 days after. This baby is at high risk of transmission and high risk of mortality. So IVIG has to be given and acyclovir also, because mostly the baby gets symptoms. Breast milk can be given if no lesions on the breast, but proper hygiene has to be maintained. So this is the already we have seen first trimester is for congenital varicella syndrome, and -5 to +2 is the maximum severe risk. And for preterm babies less than 28, less than 1 kg, even if mother gets till 21 days before, they are at risk. So IVIG has to be given for them also. The incubation period of varicella is 10 to 21 days. So even so after birth, if till 21 days it could be still be perinatal infection from the mother. But after 21 days, if symptoms develop, it mostly neonatal. So we can see in this table, first 20 weeks is congenital varicella. The percentage transmission is 2% only, but fatality rate is 30%. And in third trimester, the incidence is 10 to 20% chance of transmission, but fatality rate is less. So the outcomes, if we see, if mother onset of rash is 5 days before, then the more than 5 days before, then mostly deaths are not seen. But if it is -5 to +2, there is 20% risk of mortality. So treatment will be, if it is -5 to +2 days, then this baby needs admission. IVIG has to be given, and IV acyclovir is given in this case. Isolation, preferably yes, but mother has to at least maintain hygiene, wear mask, and has to be apart as far as possible, and then breast milk has to be given. If it is -21 to -6 days, then again this baby may develop symptoms, so we have to admit. IVIG at least has to be given, and if baby is stable, then we can discharge on oral acyclovir. But if baby is sick, then IV acyclovir has to be given. Hygiene has to be maintained. Breast milk can safely be given. If after 3 days till 28 days this mother gets varicella, then admission will depend. If baby is stable, then no need to admit, because IVIG we don't have to give. Oral acyclovir alone is enough, and with proper hygiene we can give breast milk. The dose of IVIG is 0.4 grams per kg. Oral acyclovir is 80 mg per kg. IV acyclovir dose is 30 mg per kg per day. This we have to give from day 7 of the maternal onset of rash. Next question. This is 36-year, 12 weeks of gestation. This dual marker test has come high risk for trisomy 21. 12 plus 2 weeks gestation, and there are high chances of trisomy 21 as per the dual marker test. So the question are, what non-invasive test can be advised in this mother, and what is the sensitivity in picking up trisomy 21? And if this test comes positive, what next? And is there any maternal conditions that can cause low fetal fraction? So false negative report we may get in some cases. NIPT 99%, amniocentesis, obesity, NIPT, NIPT. So most of the students are answering correctly. So most of the other questions will also be mostly practical points only. It's just a revision. So mostly we'll finish by 7. That is the scheduled time. If positive result, amniocentesis. So we'll see the answers. NIPT around 99% sensitivity, specificity, and it's not a confirmatory test. So depending on the gestation, we have to do chorionic villus sampling or amniocentesis. And obesity and multiple pregnancies, there are chances of false negative. Although a rare chance, it's not very common, but in these cases we may get false negative. So NIPT is a non-invasive prenatal testing. The concept is that fetal DNAs will be seen in the maternal circulation. So if we take the maternal blood, then we can get an idea. So NIPT routinely should be done if the maternal age is more than 35 at delivery. Fetal ultrasound is showing increased risk of aneuploidy, or the previous pregnancy had a trisomy or aneuploidy, or the blood reports are showing high risk of blind aneuploidy, then this non-invasive test we can do. Results, mostly the sensitivity specificity is good, 98-99% for trisomies 21, 18 and 13. But the positive predictive value for 13 and 18 is not very good. Positive predictive value of 65 in trisomy 18 and 37 in 13. 37 in 13 means if test comes positive, there are 37% chances this is actually trisomy 13, and 63% chance this may not be trisomy 13. So if NIPT we are getting positive result for trisomy 13 or 18, we must confirm it anyway because the positive predictive value is less. Some causes of false negative test is early gestation if we do before 10 weeks, or in obesity, multiple pregnancies, IVF conception, mother on low molecular weight heparin. So these are few causes. Next question. This is on stillbirth, 29 weeks of gestation, and this baby delivered as stillbirth. So questions ask, fetal death beyond what gestation is considered stillbirth as per WHO. Beyond what gestation we have to report. The stillbirth reporting is done beyond what gestation. And apart from thorough physical examination, any other investigations you want to do if a stillbirth has happened? First is 28 weeks, 28 weeks. '24, 28. Placenta examination, karyotyping, autopsy, karyotyping, 28, 1 kg ground lump length. Nikhar is answering well. Detailed answers, good. Okay, most of you have answered right in parts, so we'll just see. So as per WHO, it is more than 28 weeks, more than 1 kg, but the reporting of stillbirth has to be done beyond 20 weeks. And other tests, we should rule out the genetic parts, autopsy if indicated, and congenital infections. So these things we have to rule out. So there is a proforma as per NHM, stillbirth proforma, which the gynecologist obstetrician they have to fill and submit. So every stillbirth beyond 20 weeks, they have to fill this proforma. That's a long proforma they have to fill that has some basic information, maternal history. So I'll just show the proforma. This is the basic information they have to write. Then the maternal history, the current pregnancy details, antepartum complications, if any, then examination of the mother, general vitals, abdomen, vaginal investigations, all the investigations of this pregnancy, then the details of labor, normal, cesarean, placenta examination, someone mentioned that also is important. Then delivery details. Then this is our part, the baby details. Then we have to examine the baby. We have to write if any congenital visible abnormalities are there, what is the birth weight is there, what is the sex of the baby, if any visible anomalies are there. Then the basic investigations we can do if relevant, infantogram if anomalies are there, and then autopsy. The finally this cause of fetal death also they have to mention and submit this detailed report. So if no cause is obvious from the history and detailed investigations, then autopsy also can be offered to the family. So the next question on thrombocytopenia in neonate. So at 6 hours of life, newborn was seen with petechiae purpura. Platelet count is 18,000. Mother's platelet count is normal. The initial sepsis screen is negative, and baby is active and feeding well. So a well baby with platelet 18,000 with mother's platelet counts being normal at 6 hours. What is the diagnosis? Two differentials. What is the investigation of choice for most possible diagnosis in this case? What will be the treatment of choice? And what serious complication must be ruled out urgently? And what is the recurrence risk in next pregnancy? So if you want to see the scenario, so this is at 6 hours, 18,000 platelets. Mother's platelets are normal. Baby is well. What is the possible diagnosis? Or maybe two differentials you can mention. And the best possible diagnosis, what is the investigation? NAIT, many have answered. Other investigations. So, in what will be the investigation of choice? Matlab, how will you diagnose NAIT? Investigations, I mean, how will you diagnose NAIT for the diagnosis? HPA testing. HPA testing, antigen testing, antibody testing, mother, father. Rule out IVH, maternal antibodies, placental antigen. So many have answered correctly. We'll see the answers. And then how will you manage the next pregnancy antenatally? Now, during pregnancy, next time, what will be the treatment? IVIG. Someone mentioned IVIG. Any other thing? Or any other? So we'll see the answers. NAIT or anytime thrombocytopenia is there, sepsis should be ruled out. Correctly answered HPA testing for the so genotyping, the genetic testing will be done for both the parents, and antibody testing in the mother we can do anti-HPA antibody testing. So this newborn we have to give platelets if as it is less than 30,000. 30,000 is the target we have to maintain. So platelet transfusion has to be given and IVIG also. So if we are suspecting NAIT, IVH has to be ruled out. And if one pregnancy has NAIT, there are 75 to 90% chance the next pregnancy again may develop NAIT. So antenatal in that pregnancy, then we'll have to give antenatal IVIG. That monitoring we'll see. So NAIT, what is happening is antibody is produced by the mother against the specific HPA in the fetus, and that HPA that fetus has got from the father. This is the most common cause of early onset severe thrombocytopenia in well babies. Roughly incidence is 1 in 1,000 well appearing babies. ICH we have to rule out. Sometimes intrauterine antenatal in 50-60% cases there may be antenatally only this intracranial bleed may happen. And if the father is homozygous, then there is 100% risk of recurrence. But overall, it's 75 to 90% chance. But if it is homozygous variant, then the next pregnancy 100%. Investigations, so HPA has to be tested in both the parents. In mother, we can do anti-HPA antibody testing, and in the baby, ultrasound cranium should be done to rule out bleeding. So platelet cutoffs for NAIT is 30,000, and if there is a major bleed or intracranial bleed, then 50,000 cutoff at least we have to maintain. IVIG dose is 1 gram per kg for 2 days. Steroids plus minus can be included if we are not able to manage with RDP and IVIG, then steroids also may be added. Usually this NAIT resolves in 1 to 2 weeks, and follow up till platelets are normal, then we can. So if the previous pregnancy is NAIT, then the risk is 100% for homozygous. And fetal genetic testing can be done from mother's plasma. Cesarean has to be, elective cesarean is not the vaginal, but cesarean is preferred at 37 weeks. And this starting IVIG depends on the severity of thrombocytopenia and ICH in the previous pregnancy. So if it was severe enough, then we have to start at 12 weeks, but usually 20 to 26 weeks, around 20 weeks, we usually start 20 to 26 weeks. So IVIG is usually given weekly, plus minus steroids can be added. Next question. So half we have finished. So this is about the vaccines. Again, a simple question. So this pregnancy is 20 weeks of gestation, 26 weeks of gestation. So which vaccines are safe in pregnancy and which vaccines will harm the pregnancy? So three questions. Two vaccines that is given to all during pregnancy and two vaccines that are contraindicated in the pregnancy. And what do we mean by cocoon vaccination? Tdap is safe. Tdap. Tetanus, influenza, Tdap, influenza. So in previous question, Kalyani was asking whether sepsis was ruled out. So this is just a framed questions. Sepsis anyway should be ruled out, but that we wanted to discuss NEIT here, so that details of sepsis workup I have not mentioned. So cocooning is family members for flu. Live vaccines are contraindicated. Vaccination of the family members. MMR is contraindicated. OPB. Cocoon is passive and administration loss content. So everyone is answering correctly. We'll go through the answers. Tdap and influenza, correctly mentioned, are the two vaccines that are given in pregnancy. Live vaccines, MMR, varicella, are contraindicated. Even live influenza is also contraindicated. Cocooning means the close members are given vaccination so that the baby gets the benefit. So if preterm is there in NICU, we can give vaccination to the family members. Even in NICU preterm babies, also the family members or all the close contacts can be vaccinated with influenza to prevent flu in the baby. So vaccinations is the same. Tdap and influenza and contraindicated are these three, and all the live vaccines. Next question. Only three questions are left. Four questions. This is on fetal tachycardia. 32 weeks of gestation. There is fetal tachycardia. Heart rate is going above 240. There is no cardiac anomaly. No structural cardiac anomaly, only mild ascites is noted. Persistent fetal tachycardia, antenatal, 32 weeks of gestation, heart rate 240. What is the diagnosis? What drugs we give antenatally? This is antenatal. Fetal, I'm sorry, SVT, I mentioned the, okay. So the complications of antenatal SVT, how to treat antenatal SVT. Anemia, PSVT, fetal SVT, maternal fever, anemia. Yes, physiological may be there, but 240 will not happen by fever. PSVT, SVT, flecainide, digoxin, fetal death can happen. Digoxin, SVT, digoxin, flecainide. I think you are answering very quickly. Typing is very fast these days for everyone. Very right. So everyone is answering correctly. We'll go through the answers. SVT, I already mentioned in the second question, and mostly drugs are digoxin, flecainide, sotalol. These are the drugs is preferred in antenatal SVT. Hydrops is one of the complication that can happen because of arrhythmia. So fetal tachycardia is defined above 180. The chances is 1 in 1000 to 2000 pregnancies. SVT is most common, 70% causes of fetal tachycardia. This abnormal pathological cause of fever and mild tachycardia anyway will be there. 28 to 32 weeks, mostly this fetal tachycardia SVT happens. Mortality is around 10% because of persistent tachycardia and hydrops as the complication. Drugs mostly used is flecainide for no if there is no hydrops, and if hydrops maybe digoxin also we may have to add, and then sotalol may be added. So all the combinations can be given. Again, a common scenario, commonly asked question, and not very common, but sometimes we see a milder degree of this picture in our NICU. 4 kgs, shoulder dystocia, uh, just soon after birth, and there is asymmetric mororeflex. Question answer. Likely diagnosis. Which nerve roots are likely involved in this case? One investigation you want to do in such case, if a baby is delivered with this difficulty, what other investigation you will ask for? Then what are the chances of good outcome in this case, or overall how long it usually takes to recover, and when is surgery indicated in such cases? Shoulder dystocia 4 kg, Erb's palsy C5 to C7, lower brachial plexus chest X-ray, 100% recovery by 6 months, spontaneous recovery 3 to 4 months, X-ray for clavicle fracture, NCV 3 months, X-ray, EMG, ultrasound, surgery after 1 year. So more or less, at least everyone will pass. 50% answers are anyway correct for everyone. Erb's palsy C5 to C7 correctly answered because wrist drop is also there. X-ray shoulder anyway has to be ruled out for fracture. So any baby with this difficulty, fracture clavicle should be ruled out, correctly answered. Most cases recover by 3 months, 70 to 80%, not 100%. And surgery, mostly some improvement will be noted by 3 months. So beyond 3 months, if there is no improvement, then surgery is considered. 1 year will be a little late. Now these days they are actively intervening early. So one classification is there based on which we can classify how many nerve roots are involved. So if there is no wrist drop, then C7 is not involved. If there is just shoulder adduction, external rotation, elbow flexion, if these are affected, then abduction is affected, shoulder abduction is affected, external rotation is affected, elbow flexion is affected only, then C5, C6. If wrist drop is also there, then C7 is also affected. And the lower nerve C8, T1, if that is also affected, then there is complete paralysis. Even the grasp reflex is affected, will be abnormal. If C8, T1 is involved, then that the grasp also we will not get, the hand grasp will not get. And Horner syndrome should be seen. So pupils should be examined and to rule out Horner's meiosis and hydrosis. So Horner syndrome should be ruled out. So if there are less nerves involved, then if only C5, C6, then mostly 80% recovers. If there is wrist drop still, but other things are not there, then again 60% recovery. But if there is complete paralysis, then 30 to 50% chances of good recovery. And if Horner syndrome is also there, then it's still very bad prognosis. So in neonatal brachial plexus injury, the incidence is around 0.4 to 4 per thousand. This Narakas, they have divided into four groups. These are the four groups. So the first group is most commonly seen, 50% of the cases. The risk factors are shoulder dystocia, macrosomia more than 4 kg, clavicle fracture, humerus fracture. These should be ruled out by X-ray. Diagnosis is mostly clinical. Risk factors will give us an idea. Birth history will give a clue. Asymmetric moros we can observe in the newborn. And sometimes this C3, C4 may also be involved. So the respiratory status also should be checked. Treatment mostly will depend, mostly is conservative. We have to prevent contractures, maintain the range of motion, and close follow-up and serial examination is advised. For prognosis, we have to see the biceps function, and the grasp will also give an idea. So if there is a biceps function coming up by 1 month, then mostly this baby will do good. If is able to flex the arm, biceps has come up, biceps function. If hand grasp is there, then mostly C8 is not involved. So it's mostly upper fibers are involved, so that they have good outcome. If there is no biceps function by 3 months, then mostly I think this baby will go to surgery. They are considering surgery if there is no biceps function by 3 months. And high grade injuries, there may be 20-30% residual defects, deficit may be there. Second last question, this is on antenatal hydronephrosis. 32 weeks of gestation, we are seeing APD, anti-posterior, anteroposterior diameter is 11 mm. There is no ureteric dilatation. Bladder is normal. Amniotic fluid is normal. There is no oligohydramnios. 32 weeks, 11 mm. Question is, what is the severity of antenatal hydronephrosis? When to perform ultrasound, KUB? When to perform MCUG? Whether to give antibiotic prophylaxis in this case? Moderate ultrasound beyond 48 hours, ultrasound after 48 to 72. If persistent, then VCUG. So if persistent VCUG, then when to do VCUG? Persistent for how long? Mild, moderate, severe, more than 10? So we have to answer is, in this case, 32 weeks of gestation, APD is 11 mm. What is the severity? When to perform ultrasound? If lower unit tract obstruction, then VCUG. Ultrasound 48 to 7 days or before discharge, 4 weeks. Okay. Correct. Moderate. MCG indication moderate to severe pilotis AP more than 10 mm. Correct. So almost everyone is answering correctly. One more question. Which drug to give for antibiotic prophylaxis? Which medicine? Cephalexin. Answer is correct. Spelling is wrong. Moderate hydronephrosis correctly answered beyond 48 hours. MCUG is indicated 4 to 6 weeks. At 4 to 6 weeks. That also will depend on the ultrasound finding. We'll see the flow charts later. and antibiotic because it's more than 10, so we'll give antibiotic prophylaxis, and cephalexin is preferred, 10 mg per kg per day. So classification is as per this table. Mild is for second trimester 4 to 7, moderate 7 to 10, severe more than 10. But for third trimester, it's 7 to 9, mild, more than 9, 10 to 15, you can say moderate, and more than 15 is severe. If we are suspecting lower urinary tract obstruction, so the ultrasound features will be bilateral hydronephrosis, thick bladder wall, oligohydramnios, dilated posterior urethra. So these findings may suggest lower urinary tract obstruction. So if there is lower urinary tract obstruction symptoms suspicion, then we have to do within 24 to 48 hours. In other cases, 3 to 7 days. So beyond 48 hours, we should do ultrasound. MCUG indication, they are mentioning if APD diameter is more than 10, then you do, but later. Early, that we have to do at 4 to 6 weeks. And 24 to 72 hours MCUG should be done if we are suspecting lower urinary tract obstruction. And if the baby with antenatal hydronephrosis develops UTI, then we have to do MCUG. So MCUG has to be done if more than 10 mm APD, and if develops UTI, and if there is suspected lower urinary tract, then within 24 to 72 hours we can do MCUG. And DTPA, or the renal dynamic scan, that is advised if APD is more than 10 mm and there is no reflux. If there is reflux, then no need to do DTPA. If there is no reflux in MCUG, then DTPA has to be done. So DTPA gives us the differential function, whether there is any obstruction is there or no obstruction. So this is the flow chart. This is the previous flow chart. This 22, the pediatric nephrology, they have come up with a new flow chart. So what anyway we have to do a repeat scan at 4 to 6 weeks. So if there is less than 10 mm after at 4 to 6 weeks, the diameter is less than 10 mm, then no intervention is required. If it is 10 to 15, then continue monitoring. If it is more than 15, or if more than 10 with associated with any other renal abnormalities are there, or oligohydramnios is there, then they are in that case also. And otherwise, if no other abnormality is there, then more than 15 now they are telling. Previously it was more than 10 for everyone. Now they are telling if more than 10 with anomalies, otherwise more than 15. For those cases we have to do the MCUG. If MCUG is showing reflux, then antibiotic prophylaxis. If there is no reflux, then DTPA scan or MAC3 scan is to be done. If lower urinary tract obstruction is seen, then surgery has to be done. And if DTPA suggests obstruction, then again surgery is done. The antibiotic given is cephalexin, mostly 10 mg per kg. Cotrimoxazole and nitrofurantoin is for beyond 3 months. Drug of choice for prophylaxis beyond 3 months. Last question on alcohol. 28-year-old girl. Alcohol is now very common. We are developed country now. So regular alcohol intake. This girl is having a history of frequent parties and regular alcohol intake. And now this girl unfortunately is pregnant. So regarding alcohol, she has many questions which which you will answer. How much alcohol is safe during pregnancy? What are the three side effects of excess alcohol during pregnancy? Which trimester it is most detrimental? Also advise on alcohol intake after delivery. Alcohol intake after delivery, can we take, not take? If we can take, what advice? So one question is during pregnancy, one is after pregnancy, and 3 side effects and which trimester. No one is answering. Only one answer is there. No amount is safe. Fetal alcohol syndrome, low birth weight, IUGR, learning disabilities, facial abnormalities. Very good. Fetal alcohol syndrome, IUGR, third trimester. First trimester. Time is already 7:10. Oh my god. I'll just finish in 2 minutes, 3 minutes. Fetal alcohol, neurodevelopment, not safe. Fetal alcohol, very good. So everyone is answering correctly. And just two facial features of fetal alcohol syndrome, if you remember. Any specific facial features of fetal alcohol syndrome? Thin upper lip, very good. Small philtrum, very good. Perfect. So no safe level during the pregnancy, very good. Preterm birth, stillbirth, then growth problems like low birth weight, IUGR may happen, and then the neurodevelopment part, the intellectual disability, behavior, cognition, learning problems, all may happen. There is no safe period, but first trimester, because that is the development phase, so facial also may be affected. That facial features are common in first trimester. One standard drink per day can be taken after delivery, but we have to wait for at least 2 hours after consumption. One standard drink. That definition we'll see in the next slide. And the facial features are smooth philtrum, thin upper lip, small eye opening. So these are the facial features: smooth philtrum, thin upper lip, and small eye opening, small palpebral fissures. And one standard drink is if you are taking beer, 12 ounce. 12 ounce means 360 ml. This 7% malt liquor is 8 ounce, 8 ounce 240 ml. Wine we can take is 150 ml. And if we are taking vodka, whiskey, gin, rum, then 45 ml maximum. But if we want to take more, then more gap has to be given. The peak level in the milk is 30 to 60 minutes after consuming alcohol. So alcohol in milk, if you are taking one drink, then 2-3 hours gap we have to give. After 2-3 hours, the concentration in the milk will not be significant, so then she can give her milk. If she's taking more, then 4 to 5 hours we have to give for 2 drinks, and 6 to 8 hours gap for 3 drinks. So over to Dr. Swati to explain this curve.
I think you can go ahead with it and explain this.
So lot of answers and topics we have come across today, 20 different topics and lot of theory we have learned now. So this Ebbinghaus, I don't know how to pronounce. This person has told us that the if we are not revising, then mostly in near future we'll forget everything. What he mentions is within 1 hour we forget around 50% of what we have learned. So by after dinner, I think 50% will be gone. By tomorrow, 66% will be gone, and in a week 75% will be gone. So how we can reduce it is if we review once after 24 hours, then retention is 80%. After a week also, if again we revise, then it stays at 80, and then after a month again, then it's long term. So we have to revise these. These are the basic questions anyway. So just you can go through these topics once. If you, we will share the slides also. If you want, you can go through the slides again. Okay.
Yeah. So thank you, Dr. Amrit, and thank you, Ashish sir, for a very comprehensive coverage of the topic. And it was really a learning experience for us as well, sir. Many questions were there which are not regularly taught and which are not we even skip. So it was really a learning experience for all of us. And thank you for sparing your precious time for conducting this OSCE session, sir and Dr. Amrit. Bish sir, do you want to say a few words?
Thank you, Swati, for conducting it so smoothly. And thank you, Ashish and Amrit. Despite the 5 minute delay, I think we could end well in time. And we are so happy that the OSCEs are going so well. And Ashish and Amit both have worked so hard. And that's the best way of learning, the way the questions are asked and the kind of you were trying to describe the answer so well. I think, Amrit, the Abengos forgetting curve will not go because you are asking questions and then you are discussing them. So I think
Hmm.
there would be retention more than what you are saying. And yes,
Hmm.
you have given them the mantra to retain it if they will review it in tomorrow and then after a week or so. Yeah.
And
Congratulations to all.
thank you,
Thank
sir.
you all.
Everyone has answered also correctly, so all our knowledgeable audience we have.
So it is etched.
Hmm.
Thank you so much, sir. Ashish, sir, any advice for the candidates and your words, please.
Hmm.
Ashish, sir.
Hmm.
I think he has logged out. Ashish is not there. Swati? Yeah, just logged out. Yeah. Thank you. Thank you. Great, great.
Thank you,
Thank you,
sir.
sir.
Thank
Thank
you,
you, sir,
everybody.
for the
Please
opportunity.
attend all the sessions. Please answer. Please interact. Please be